For the wrist imaging, our techniques are PA, lateral, PA oblique, ulnar deviation, and Stetcher method. For the PA technique, the patient must be seated at the end of the table, with the axillary in contact with the table or the hand position. The patient must rest her forearm on the table, and we would need to center the wrist to the IR. They would need to flex their digits slightly to place their wrist in contact with the IR. Our central ray is perpendicular to the mid-carpal area, and our collimator is set so that the radiation hits 2.55 inches or 6 centimeters proximal and wrist onto the wrist joint, and 1 inch or 2.5 centimeters on the sides. In the lateral imaging of the wrist, like the PA imaging, the patient must be seated at the end of the radiographic table with their axilla in contact with the table. They would need to flex their elbow 90 degrees like so that their arm and forearm are in contact with the table. Their carpals must be centered to the IR, and we would need to adjust their hands so their wrist is in true lateral position. Our collimator is the same as the previous technique, but our KBP is a slightly higher ceiling than the 70 kilovolts. In PA oblique or lateral rotation imaging of the wrist, the patient must be seated at the end of the table with their axilla in contact with the table. The wrist must be centered to the IR and its anterior surface resting on it. We would need to rotate the wrist approximately 4 to 5 degrees laterally and support it with a sponge. This sponge support is optimal, but not necessary. Our central rate is perpendicular to the IR and entering to a mid-carpal area, just this style to the radius. We have the same collimator setting as all previous techniques, and our KBP is 66. For the ulnar deviation technique, the patient, like any other technique that we went through, must be seated at the end of the table with their axilla in contact with the table. They would need to flex their elbows 90 degrees while their forearm and arm are in contact with the table. They must center the wrist to the IR without moving their forearm. They need to turn their hand outwards until their wrist is in extreme ulnar deviation. Our central leg is perpendicular to the scuff weight, but if necessary to delineate any fractures, we would need to angle the central leg 10 to 15 degrees proximally or distally. The collimator is the same to any other wrist technique, and our KVP is 66. In a Stetcher method, or PA axle, the patient is seated at the end of the table with their arm and axilla in contact with the table. We would need to place one end of the IR on a support and adjust that so that the fingers are elevated 20 degrees. We would need to adjust the wrist for PA projection and center wrist to the IR. Our central leg is perpendicular to the table this time and positioned to enter the scuff weight. Our column motor is the same, and our KVP is 66. For the imaging of the car parking lot, we have a method named tangential or heart method. For our patient position, we must set the patient forearm parallel with a long axis of the table. For the part position, we would need to hyperextend the wrist and center it to the center of IR. If necessary, we would use a 3-4-inch radial loosen pad to support the lower forearm. We would adjust the hand position so the axis of weight is as vertical as possible. We would ask the patient to grasp the digits with the opposite hand to hold an extended position or pull with a bend. Our central array is directed to the palm of the hand 1 inch or 2.5 centimeters below to the base of the third width of the carpool at the 25 to 30 degree angle, and our KVP